with the people that are in a recovery kind of a situation.
Thank you. Let's go on and get started. Can everybody hear me? Nod if you can. Wonderful. Good afternoon, everyone, and welcome to this special session on considerations for personal protective equipment and substance use disorder treatment. This session is brought to you by the UT Health San Antonio Texas Medication for Opioid Use Disorder team. That's the last time I'll say that. I'll call them Texas Mood throughout for short. My name is Andrea Roche. I'm a Senior Research Coordinator at UT Health San Antonio, and I'm going to be facilitating today's session. We're delighted that all of you are here. If you're able to, we encourage you to join with your video. If not, we're glad you're here anyway. A few quick announcements before we begin. If you haven't done so already, please enter your name, affiliation, and email into the chat function to help us with record keeping. To access the chat feature, click on the speech bubble icon on the navigation bar at the bottom of your window. Please stay muted unless you are speaking. If you're joining us by phone, you can press *6 on your phone to unmute. If you've joined us by a computer, you can select the microphone icon in the lower left-hand corner of your screen to unmute yourself. We encourage you to ask questions, provide feedback and your own experiences throughout. You can use the chat feature to do this, or you can unmute and share those experiences. We try to categorize and address as many questions as possible during the session, but if we're not able to get to your question in time, we will send follow-up emails. We are recording this session and we will make it available online at our Texas Mood YouTube page. We'll send the link out for that in just a bit. The goal of this session is to create a space where all of us can share our questions, challenges, and solutions in this very extraordinary time. So we encourage everyone to participate. Everyone can share answers. Everyone can share questions. Today's session is going to open with a didactic presentation followed by a live Q&A, and it will end with announcements. You can ask questions again by unmuting or via the chat feature throughout. So we're going to begin with didactics, and before we start that, just a few introductions. Dr. Ruth Berggren is an infectious disease physician and the director for the Center of Medical Humanities and Ethics at UT Health San Antonio. Dr. Michael Charlton, also joining us today, is the Vice President for Risk Management and Safety at UT Health San Antonio. He is an adjunct assistant professor with the Department of Occupational and Environmental Health and an adjunct associate professor in the Department of Radiology. Thanks to both of you for joining us today. At this time, I will ask the UT Texas Mood IT to share the presentation. Looks great. Dr. Charlton, when you're ready, please begin.
Okay, well, thanks so much to everyone for joining us here today. Dr. Berggren and I are delighted to join you here and talk about this subject that has really rocked the whole entire globe the past approximately 6 months. This is an issue that I know Dr. Berggren would agree with me is extremely important, and a subject that has really been a key pivoting interest for healthcare, especially here in the United States, for at least the past 90 days. And so we wanted to take some of the experiences that we've had in Antonio, and Dr. Berggren is going to share some of her experiences working with some communal living facilities that she's worked very, very hard on the past few months, and really try to give you some ideas on things you might be able to apply in your own practices over the next few months. So let's go. Dr. Berggren, did you want to add anything to this kind of the objectives part of it before we go into a little more of the didactics?
Well, I was just going to share with the group that the other hat that I wear is I am medical advisor to Bexar County for COVID-19, and also I am a member of the health transition team appointed by the mayor, which is a group that developed guidelines for reentry into normal daily functioning, actually the new normal. So I have a lot of the backstory about what went into those discussions, and I can go into at whatever level of detail you wish in the Q&A about our progress indicators and our warning indicators and what those mean. So that's just, we'll see what people want to talk about, but I wanted to let you know a little bit more about the role I've been playing so you can think about what you want to learn from me.
So that's excellent. For those of you that are in the public health field, Dr. Bergen is able to take a lot of sort of the academic medicine and put it both into the public health realm, but also into public policy. So she has that ability to transform all those things together. So hopefully you'll get a flavor for that in her comments here this afternoon. So what we wanted to do was look at really our front line of defense, this idea of personal protective equipment, or sometimes called PPE, and how that might affect you, how that might affect your practice, and how that might affect your patients here during the pandemic situation. We'll go through some of the guidelines for what they call donning and doffing protective gear. We'll look at a couple of graphics that show you how to do that. We'll make sure we get a copy of the slides so that there won't be a test on it exactly at the end of this, but at least you'll have something to go on and something to take back with you when you get into harm's way in the future. And then we'll look at some of these kind of good ideas on the transmission or preventing the transmission part of infectious agents. So let's go to the next slide and kind of jump right into it. So probably 6 months ago, many of you probably never thought about this idea of PPE. It is something that you really can't even hardly turn on the news right now without hearing about personal protective equipment. There has been a real dearth of protective equipment here in the United States, really the whole entire year of 2020. We've had just a very limited supply due to a fair amount of it being manufactured overseas and just the widespread need for it. And so there have been just tons of articles about it. And so most hospitals, especially smaller hospitals, have really struggled with making do with the right way to protect their healthcare workers. And so I think that a lot of that had to do with the reason why we're having this meeting today, is to try to give you some of those tips about that. Let's go to the next one. And really the whole entire goal behind this is how can you do your clinical activities, your diagnostic activities, work with your clients in a way that does no harm either to them, but also in a way that allows you to protect yourself and conversely your contacts through your family members, your other clinical partners, and that sort of thing. And really our best way to do that is really kind of threefold. One, we probably won't talk about too much today, but one of them is through very diligent symptom monitoring, just meticulous symptom monitoring. We'll briefly touch on hand hygiene and some of the practices for that. And then really this idea of protective equipment. So we'll look at all those things, at least in some form or fashion here this afternoon. So let's go to the next one. And let's go to the one after that. Okay, so just kind of philosophically, if we take a step back, one of the things that we need to think about, one of the things we need to evaluate before we go into harm's way is really that anticipation part of it. We're trying to anticipate and recognize the types of exposures that we might run into in a situation like this. And so that's really kind of the front end part of it. Many of you are experienced professionals, so you probably have been through some different exposure scenarios before COVID-19. And so we should have some understanding of what to expect while we're having these patient encounters, right? So the ones that you see here on the slide really kind of highlight a couple of things for you to think about. Probably many of you have had training probably every single year on bloodborne pathogens training, and that training has been around basically my adult lifetime. So you've all had annual training on that. Some of you from the UT Health side have had my voice on that training every year for probably 20 years now. And so what this selection slide talks about is select protective equipment that is appropriate for the types of hazards that we might run into during our patient encounters, really. So the idea is there a possibility for splashes or sprays, meaning we have some sort of liquid material, versus directly just touching something, which would be just a dermal protection in the form of gloves, right? Taking that the next step, and the part that's really been a struggle here, really globally, is the idea of isolation associated with airborne precautions, right? So the virus that we've all been struggling with this year is a respiratory virus, is an airborne hazard, and so it's not just something that we have to worry about with dermal protection in the form of gloves. We certainly want to do that, but we need to add to that some additional precautions, especially in the form of respiratory protection. And so once you put those two things together, it makes the selection of protective equipment a little bit more of a challenge. And that's probably part of the reason why many of you have joined us today, is to talk about what that is, what that looks like, and how you might put that on and take that type of equipment off, right? And just along those same lines, there's a real spectrum of different kinds of protective equipment out there, right? And I don't want you to walk away from our presentation today thinking that there's a one-size-fits-all, right? There are many different types of protective equipment out there. A lot of it is really not appropriate, right? There are some people that may take advantage of the situation that we find ourselves in, where we're all kind of desperate for the correct and appropriate protection. And so it may not be as protective as you think it is, right? So some of it may be durable and some of it may not be durable. And so just I want to caution everybody to try to think through the hazards and the risks before we kind of put ourselves in harm's way, or put our patients in harm's way. Then the other part of it is really just the anatomy of all of our providers and our patients to a certain extent. There's a variety of different face sizes and shapes, and there's really not one specific type of protective equipment that fits everyone. I can say that there's a lot of different types of respiratory protection that's available to you. Unfortunately, we've been doing this for a long time, so there is a real spectrum that's available. And we should be able to find something that fits everyone. We have had a few people that it's a real challenge, but we actually are able to find something that fits even a person with a very small facial anatomy, and even a person that has a very large facial anatomy. We have been able to find a type of an equipment that is protective in nature for them also. Sometimes it can be a little bit of a challenge, but we are able to do that. Let's go to the next slide. Okay, so this is the part that I thought you might have a lot of interest in, is really the sequence of operations, really. So the best way to think about it, we want to start with the things that are closest to us, closest to our person, and then kind of work our way out from there, right? So generally speaking, we're going to start with some sort of closed front gown, right? You probably have seen it. Even if you've never worn a closed front gown before, you probably have seen them, even say when you go to get your teeth cleaned, although it's probably been a little while now because dentist offices in Texas are still currently closed. But if you think back to the last time you went to go get your teeth cleaned, your dental hygienist was wearing probably a disposable closed front gown, probably a yellow gown, that is very similar to what this is. They probably were not wearing a respirator, but they probably were wearing a surgical mask. One of those two things, probably a surgical mask. They probably were wearing a face shield, and for sure they were wearing dermal protection in the form of gloves, right? So it's all of those things kind of together, work together to protect the wearer in the event of some sort of procedure, right? One of the things we always want to make sure we do before we go into the situation is to wash our hands, practice really good hand hygiene. That way we know that we have a clean hands situation before we start handling clean protective equipment, right? So that's always an important part to start with. A lot of the attendees here, they may be working in a scenario where they don't have access to hand washing facilities. And that's not super uncommon, It is totally appropriate to use alcohol-based hand rubs in a situation like that. That's very normal. There's a fair amount of data to show that in that case, alcohol-based hand rubs are quite appropriate. So hopefully you'll have access to that if you don't have direct access to hand washing facilities. Then the two terms that you probably had never heard of before, probably 90 days ago or 6 months ago, was the term donning, which is just a kind of a fancy word for putting on or safely wearing our protective equipment. That's that process of putting it on. And then doffing is the reverse of that, where we're the process of safely removing and taking off protective equipment. So you'll hear those terms, donning and doffing, and they're associated with the putting on and taking off of protective equipment. Let's go to the next slide. Okay, so a couple of things to work through. Here's an example of one of those closed front gowns. You can see in the first graphic there, the person is putting on one, has tight cuffs on it, right? So that way you don't have huge gaps going in and around that and getting on your scrubs or your uniform. They do make these in a variety of different sizes. They do have a tendency, no matter what size you wear, pretty much none of them seem to fit correctly. I don't know why that is, but they generally seem like they don't. But there are different variety of sizes that hopefully will come pretty close to fitting you. There generally are two ties on these. You'll find that there's one at the top of the neck or the nape of the neck, and then there's also one in the midsection there. Most people, when they tie these things, they try to leave one end kind of dangling down so that it's easy to take it back off at the end. And then the same thing is true. So you would secure it at the top and then there in the midsection on the back, right? These are one with the open part towards the back if you've never worn a gown like that before. Let's go to the next slide. So once we've done that, the picture that you see here, this is an average, typical grade surgical mask. This type of protection is very normal for individuals that are not performing aerosol-based procedures, right? Anything that's an aerosol-generating procedure would be a pretty standard type of protection. This is essentially contact protection that protects your mucous membranes from any kind of materials in the air, and also secondarily has the ability of protecting others working around you from any kind of aerosols you might be given while talking or chatting with your patients. Okay, you can see just relatively straightforward. It has two ties. Probably everybody has worn these now at this point. It'll have two ties, one at the top of the head and one at the mid neck there. Pretty straightforward. They are relatively easy to adjust, literally just a matter of cinching them down, kind of similar to wearing a belt or something like that. The one caveat that I always like to remind people about, this type of mask is going to be in direct contact with your nose, your mouth to a certain extent. So you never want to touch the inside of a mask with your bare hands. There's a real good chance of getting fomites or contamination of some sort on the inside of your mask. So you want to avoid touching the interior part of that is in direct contact with your face as much as possible. At the bridge of the nose, there is a kind of a flexible, formable piece there. Normally it's a small piece of metal or formable plastic. And you should push that down and create, it's not a tight seal, but it's a secure seal all around the bridge of your nose. It is somewhat adjustable to your face. It's generally speaking not a great fit, but it's somewhat adjustable. Okay, let's go to the next one, which will show you some respiratory protection. The image that you see here it's not great, but it is supposed to be an N95 respirator, which you may have seen, you probably have seen, if nothing else, you've probably seen news articles. An N95 respirator is a tight fitting, and it is a filtering fabric respirator, and it has real tight bands that go around the back of your head. It is, you'll see people wearing them, if you go to your grocery store now, you'll see people wearing them if nothing else. They're very common. They are intended to be worn with both of the straps the elastic straps tight against your face. There are several different sizes of this. As I mentioned earlier, there are people with different size anatomy, so you'll have a couple of different sizes of these things. They are intended to filter through the fabric before you breathe it. The number 95 that's in this type of a respirator means that it's filtering 95% of particles of a very specific size before you respire them. So there is a variety of different respirators that are out there. The N95 is probably the most common that you'll find in healthcare. You probably are familiar with seeing some like gas masks, is what people might call them. You don't see those real commonly in healthcare. Many procedures can be quite long, and so they can be a little bit uncomfortable to wear. An N95 is relatively comfortable to wear, even for extended periods of time. And it does require a couple of things. Probably one of the things that's most important, a person does need to be healthy enough in order to wear something that is essentially covering your nose and your mouth, right? So this is restricting your ability to breathe, and not everyone is medically qualified to wear that. So that's one caveat. The second caveat, and this causes a little bit of problems, is we do need to make sure that a person is clean shaven in order to get a tight seal. If a person is not clean shaven, you'll actually get air leaking in around the side rather than going through the front face filtering part of it. Okay. Generally speaking, a person is fit tested or tested in order to make sure that it actually fits on their face correctly, right? So there's a way to do that. A couple of different ways to do that. I'm not going to belabor that point too much here today, but suffice it to say, there's a couple of things you need to do. So contrast that with wearing a surgical mask, right? A surgical mask, you literally just take it out of the box, you sort of cinch it to your head. An N95 respirator takes a little bit of work on the front end, but it's quite a bit more protective in nature. Okay. Let's go to the next slide. Here's a couple of examples of wearing face protection. Obviously, there would be a concern with respiratory virus about having eye contact with it. So the two sorts of things you see here, one would be typical goggles like you might see in more of a chemical sort of exposure scenario. And then probably many of you are familiar with the face shields that you see here on the bottom right-hand side. Most hospitals or clinical facilities, they'll use face shields, probably disposable ones with a thin plastic that look verbatim to the picture that you see there, and they are somewhat adjustable also. Let's go to the next slide. And putting on the gloves. The only thing I'll say here, but hopefully everybody on the call here has had some experience wearing gloves. The only thing we're trying to do in the picture here is there are a variety of different sizes of gloves, right? There's many. Normally you'll find 3 different sizes in most clinical facilities, small, medium, and large. You are essentially trying to make sure you have no gaps here between the gloves and the cuffs that are on that. So hopefully that makes sense. Let's go to the next slide. Andrea's giving me the 10-minute warning sign, so I'll try to go as fast as I can, I swear. So just a couple of things to think about. You do want to, when working with really any kind of infectious patient, you want to try to avoid touching your face as much as possible. And normally when I do this lecture live and in living color, as soon as I tell people to stop touching their face, inevitably somebody will start touching their face. And it's just the way that the human mind works. You guys probably know that better than I do. You really want to try to avoid touching your face as much as possible. It would be possible to transmit with contaminated hands, to transmit it to your mucous membrane. It is a relatively infectious virus, and so that is a possible route of exposure is doing that. We want to obviously try to limit any kind of horizontal surfaces that we're touching. Generally speaking, we want to start with the clean things and work towards dirty things rather than working from dirty things to work to the clean things, because then we're not going to have any clean things. Generally, you're going to clean or change your gloves out anytime they are damaged or contaminated. Obviously, if it's contaminated with blood, that's pretty easy. If it's contaminated with viral RNA, it's a little harder to see that. So you just kind of have to use your best judgment with that sort of thing. Let's go to the next slide. And in terms of here's a couple of pictures for you. Hopefully everybody can look as handsome as this gentleman. Oh, actually, I can't even tell if it's a gentleman or not, but the picture on the left-hand side shows a picture of a person wearing an N95 respirator, right? That's a tight form, filtering face piece. And then the picture on the right is very similar, but instead they have a surgical mask on in that picture. Let's go to the next one. Those are CT graphics. Okay. Obviously, we would need to have protective equipment on before we go in and have direct contact with the patient. We want to try to leave that in place for the duration of the time that we're interviewing this person or taking vitals or whatever it is that you guys might be doing. And then we would move through the interview process as deliberately as possible, and then we would move out of that area and start the doffing process. So let's go to the next slide. And I'm just going to go briefly through the removal part of it so I can turn it over to Ruth. So there's two different methods that are shown here. The method one really goes piece by piece by piece. So gloves, goggles, face shield, gown, then respirator, then hand washing. Okay. Let's go to method number two, which I think you'll find is a little bit, here's removal of the gloves. Let's go past that. Let's go past that. Let's go past that one. Let's go past that one. Here's removing a respirator is taking those elastic pieces off and then discarding them. Some medical facilities actually sterilize N95 respirators right now. That's somewhat of a new development in the past few months because of the limited supply of them. For most of my working lifetime, we've just disposed of them, and so essentially they were single use. There are some sterilizers that are able to sterilize N95 respirators right now. Let's go to the next one. Okay, so I think you'll find this method is a little bit more common, right? And I agree, it's a little bit long here. So the first thing we would do is use an alcohol-based hand rub to sanitize our gloves. That way we know we're starting with clean hands, or at least clean gloves, right? Then essentially what we do is we're breaking the ties in the back. These are just disposable gowns, so very easy to do. It's not like you're the Hulk or anything. Like, it's very straightforward to do. And then you sort of lean forward and you're removing the gown, the yellow gown, and the gloves at the same time, right? And you sort of make that into a large ball, and then we dispose of that. So at that point now we have bare hands, but we still have our face shield, goggles, and our respirator on. So we would remove these things here, kind of working through those things as best we can, and then the very first thing we want to do, the very last thing after we exit the patient room, we want to make sure that we sanitize our hands, then we take our respirator off, and then we are sanitizing. There's a fair amount of hand sanitation that is really inherent with working around the patients, and I can't overstress the importance of that enough. And it is something that is really critical, at least in terms of preventing our contamination or contamination control. Let's go to the last little bit that talks about that. Oh, here's the image of those. So this kind of leaning forward. Yeah, let's go to the hand hygiene part. So here's the hand hygiene. Probably many of you have had a fair amount of experience with the hand hygiene. There are many videos on it. The CDC has a couple of really nice videos on it. We probably don't have enough time to go through hand hygiene here specifically, but here's a little bit of information on it. You probably have had work just with regular standard precautions or universal precautions. The picture on the right-hand side shows a picture of a person working with alcohol-based hand rubs. Okay, let me turn it over to Dr. Berggren. Let's go to the next one. Okay.
Hi. So, Mike, are there additional slides here, or did you want me to launch into talking about my experience about how the real world and people putting this together?
Sure, and I'll just finish here on the Texas Medical Board. The Texas Medical Board, literally just on Friday, so I'm kind of glad we had this meeting today, issued several minimum safety standards associated with patient care in Texas. They're all listed on here, so I'm not going to go through all of them. But essentially, what it requires is both the healthcare worker and the patient to be masked. And it's okay to have just a surgical mask in a case like this. But this does apply to all licensees in Texas. So that's one issue that I just wanted to bring up to everybody, just to make you aware. There's some posting requirements and other sorts of things, but that's just a take-home message. Let me turn it over to Dr. Bergman now. She can talk about her kind of real-life procedures.
Okay, thank you very much, everybody. I just wanted to make a quick comment or two about this Texas Medical Board rule while it's still up. For purposes of y'all's work, I'm imagining that in most instances you won't be needing an N95. However, let me say this, people who are actively coughing, who have COVID-19 disease, are essentially aerosolizing. And so if you have to be with a patient who is COVID positive or a person under investigation, a PUI for COVID, and you have to be working with that person, that is an instance where it would be appropriate to have an N95 respirator. Be aware that they are supposed to be fitted, and a lot of people are using N95s without going through the fit testing procedure, which takes 15 minutes. And many people don't realize that men with facial hair have difficulty using the N95s correctly, and it can be worse. And some people say it could be worse than no mask at all if you're trying to put an N95 over a beard without a good fit. So be aware of those things. But with respect to masking, this is a good idea. And mostly what you're doing in this context of the Texas Medical Board rule is you are, the person wearing the mask is protecting the other guy from possibly getting COVID-19 rather than vice versa. So if you're not wearing a real respirator mask, the main accomplishment is you're protecting somebody else from getting SARS-CoV-2 virus from you if you sneeze, should you happen to be asymptomatic. So we can talk more about that if anybody has questions. And by the way, are there questions going on in the chat? I don't see any right now. So please, I'm going to open up the chat on my screen and I'll watch it. So feel free to ask questions as we go and I'll try to address them. What's in the next slide here? So they're both aerosol and non-aerosol generating procedures, as I just alluded. If you're performing a physical exam, taking the vitals, cleaning a patient room, drawing blood, or taking a medical history, this is non-aerosol, unless, of course, you're speaking to someone who's coughing, coughing, coughing. And the aerosol generating procedures are airway suctioning, sputum induction, actually putting a tube into somebody to put them on a ventilator, a nebulizer treatment, though, so that's a common thing that people even do in their home, right? A nebulizer treatment to, say, a kid with asthma, and then manual bag ventilation. But those are the aerosol and non-aerosol generating procedures. Next slide. So for your standard precautions PPE, we've gone over what those look like and how to put them on and how to take them off. You know, for your purposes, gloves are probably not really going to be an issue. But if there is a possibility of you're going to have to touch or come into contact with body fluids of some kind, then gloves would be a good idea. Just make sure you wash your hands before you put them on and do hand hygiene. Take them off properly and do hand hygiene after you take them off. And I think that the most relevant one is the mask for the kind of counseling that I understand that y'all get involved with. Next. So then I guess what's worth highlighting here on this slide is that we do think this virus is mainly spread through respiratory droplets. And so the droplet precautions are what we're using. There is some concern that if there's an aerosol generating procedure that there could be virus hanging about in the air for a longer period of time, perhaps hours, and we're still learning about this. But for now, we're focusing on droplet precautions and the use of surgical masks if we're within 3 feet of a patient. Next slide. So it goes straight to questions, which I've already invited them and said you're welcome at any time. It's going to be really key as we reopen here that we have everybody strictly adhering to the new hygiene procedures. And human habits are really, really hard to change. You've probably heard the joke about how many shrinks does it take to change a light bulb? And the answer is just one, but the light bulb has to really want to change. And we can know what to do, we can have access to the PPE, but knowledge plus access does not necessarily equal behavior change. And I saw this firsthand visiting some nursing homes. When we walked in, we saw all kinds of realities. One place we were very focused on their air ducts for some reason, and all of a sudden we looked around and realized that nobody was masked. Not one of the providers inside that long-term care facility had a mask on, and we said, could y'all show us your masks? And we were taken to a back room, and they had over 1,000 surgical masks. And they said, yes, we've been saving them because we were told that there's a shortage. And so memos have been sent from Metro Health, Texas Board of this and that, CDC, and yet people at this particular nursing home responded to the realities by locking up their surgical masks. We found another place where they just had no masks at all, so they were using coffee filters that were folded in half and stapling rubber bands to them for ear loops. We saw people wearing the wrong kind of mask, and we saw people wearing the masks wrong, keeping the surgical mask below their nose or using an N95 with their beards. And so none of it seems particularly complicated, but the point is that it's a change. And even really well-meaning people don't necessarily pay attention exactly when they're supposed to be paying attention. And sending people handouts and flyers and emails doesn't work all that well. So we need to think about what do we do to help people change their behavior and then sustain that behavioral change. And last week I had an interaction with someone who's in a supervisory position, and she had definitely received a memo that went out from Bexar County, but when she had an employee who had been exposed to a COVID patient and then that employee began to have symptoms, she kind of froze like a deer in the headlights and told a physician that I work with that there were no policies. Well, there were policies. And when she was gently asked about it, she was able to pull them out, but she had never had to do it. And there was this fear factor. So it's really, I think, quite helpful to review these things and to do it in a participatory fashion. So Mike Carlton is an expert, and we really appreciate his being able to guide us through it. But the truth is, because of how adults learn, if we want to make sure that we're able to carry forth and do everything that Mike told us we need to do, we need some praxis, right? We need to be donning and doffing in front of each other and critiquing each other in an affirmative kind of way to help each other keep doing it right. So my suggestion, takeaway from this, is that as you go about your work in your place of work, that you try to create a positive psychology among your coworkers, that we're going to watch each other because we're watching out for each other, and we're going to remind each other how to do it right and give people a heads up when we see somebody doing it wrong. And it'll have to be adapted to the kind of culture of your particular work environment. But it's really important not to create a punitive atmosphere. I don't think that's helpful for people. I've seen a lot of mistrust. I've had some nursing homes pretty much slam the door in our faces and not want us to come in because they figure we're there to give them a citation, which we never were about in the first place. So spending some time talking with leadership before we go into places like that has been really important to just establish that what we're here for is to make sure that everybody's safe. We're here to coach, we're here to share information, we're here to lead you to resources in case you lack them. And, hopefully that takes time. But if you're willing to invest that time up front and establish the rapport, I think it can go a lot better. The places that are going to give us trouble, congregate settings. It's going to be our long-term care facilities. And that's what we've seen already and what we're continuing to see in the jail. But testing and contact tracing in congregate settings is really, really important. It's the only tool that we have. We've gotten a lot of pushback and flack about testing in the jail because we're generating a lot of positive numbers for the city of San Antonio, and that makes people nervous, and they're saying, well, what does it really mean? Those people are in jail, they're locked up, and they're asymptomatic, so how does that change anything? But it's a very dynamic and fluid population there. 50 to 80 people go into the jail from the community every day, and about as many come out. And we do know, and it is documented in the scientific literature, that asymptomatic or pre-symptomatic spread does occur. You're most infectious when you have symptoms. People that have no symptoms are probably less than 50% as infectious, but they're not non-infectious. And so it's super important that we continue the testing in the jail. And I can promise you that our numbers show that we do have slightly more negatives than positives amongst those that we've tested so far. And we've proven that the early on infection control work we did to segregate people seems to be working, and that areas that we designated as COVID positive really are, and they're almost all positive within those areas. But we do have areas that we designated as negative that are staying that way. And that's important because if we have medically vulnerable people coming in to the jail, we've got to know that we're putting them in a place that is COVID negative, because those are the people that could die, right? It's over 65 with hypertension or COPD or diabetes or heart disease that could die, and we have a responsibility to protect them. What kind of questions?
This is Mike Charlton. I was also going to mention, Dr. Berggren mentioned communal living facilities such as a jail. There's also some literature suggesting homeless shelters, which in many cases could be a communal living situation. There's a fair amount of data from several large jurisdictions that have seen very high numbers of positives, very similar to what Dr. Berggren was reporting to you. And probably many of the callers here today, they probably work in these kind of recovery homes. They're probably not as large as those, but they could have 5 to 10 people that are in a transitional state that are working to kind of get back on their feet. And so a place like that where you have a large number of people living essentially under the same roof together, they would be maybe not the exact same as the jail facility, but it would be a concern. It would definitely be a risk, much more of a risk than, say, a person living in an individual apartment kind of a setting.
Yeah, and so there is guidance right now coming straight out of CDC and an MMWR report that people who live in congregate settings, you should have consideration of asymptomatic testing so that you can properly segregate people, because you can't give everybody a private room, but at least you could put them in different areas. And it's really important to make sure that they're 6 feet apart. That was a struggle at the jail, and there's even areas right now today that still aren't 6 feet apart because we had to open up some areas that weren't up to code and do some plumbing and so forth in order to be able to spread people apart. It's not so hard head to foot to get people 6 feet apart, but side by side and horizontally, most of those places have just 3 feet between the beds. And so anything that one can do to ameliorate those kinds of crowding situations would be very helpful. But please be aware that there is a basis for doing testing of asymptomatic people within congregate settings. We don't have specific guidance about that for jails yet, but we do have that for nursing homes and homeless shelters even.
Thank you, Dr. Berggren and Dr. Charlton. I want to open it up to questions from all of you out there about these didactics, about what you're seeing in your own practices, or about what you're anticipating to see. Feel free to use the chat feature or to unmute and raise your questions or experiences. We'll keep that as an open-ended question, and I invite you all to use the chat feature if you're not comfortable unmuting, and certainly send those thoughts in. Dr. Berggren, I wonder if you might speak to maybe what's on the horizon. We just saw a pretty detailed presentation from Dr. Charlton about precautions to take, precautions with PPE and this kind of new practice for a lot of providers, I think, especially in our audience here. Is this something that you anticipate going away pretty soon, or is this something that we're in it for the long haul, right?
I think we're in a new normal for the long haul. I say that because, you know, the fastest you could expect to have a vaccine would be, 18 months. And we worry, and it's not just me worrying, this is Dr. Fauci tells us that we should be very concerned about a second wave of infections in the fall. And certainly we know we've got to get our economy back up and running because health and economic prosperity are so tightly linked. We can't just keep protecting health and kill the economy and think that that's not also going to have repercussions on our health. So we kind of have to get back in action in spite of the fact that we don't have a vaccine. We have a better drug now that shortens the duration and does have some early indicators of improving the mortality, but it's not the kind of drug that we want to have that would make us actually feel safe. So given that's the case, as we get back into the economy, we're going to have to be strictly observing hand hygiene and masking and physical distancing. And I think still to come is going to be evidence about air circulation and management of air filters in air ducts. There's not science behind that right now, but I think that we're going to be hearing more about it, and it could change our practices as well. So this is the new reality, and we've got to get used to it. Somebody that interacts with human beings is going to have to get used to the fact that you're trying to develop a rapport when they can't see your facial expressions, and body language is so important. And so we're going to have to get smarter about using our words to convey really who we are and what our intentions are as we're trying to counsel people and assist them through a difficult time. So this is where we're going to have to teach each other how can we be healers and be effective when we can't use our normal body language and our facial expressions to communicate what we want to communicate.
Thank you for that response. Opening it up to others.
Do people have questions about going back to work? Is everybody all up to date on that? Because I'm having trouble keeping up with it. It keeps changing. Where are you at with that?
I have a comment. I'm a community health worker, and there's a lot of the people out in the community that are using the mask and wearing the gloves, but I've seen in a lot of instances where they don't know to take the precautions to remove them, how to remove their masks and how to remove their gloves. So it's like, so sometimes you wear it all this the whole day and then don't take the precautions at the end of the day or whenever you take it off to take it off properly. It kind of avoids all that precaution you took about wearing it in the first place.
That's exactly right. I mean, I saw this in nursing homes too, where people would come out of a patient care area and they're gloved and they're masked, and then they go into the break room and then they're reaching for cookies with their gloves on. So that's exactly what you don't want to do. So the thing is, we need to figure out how to help each other, right? What we're doing right now, this group of people that's here right now, we're coaching each other. We're trying to help each other understand, have the knowledge, talk about how to get access to the stuff we need, and then how to remember to do it. But there's tools we can use, such as putting posters up. Those would be like a nudge to remind people if there's a poster about how you do hand hygiene in between patients, or how to take your mask off and how to put it back on. But then when we train people, to Ms. Hernandez's point, we need to be doing this in those of us who are knowledgeable and who want to help people be safe. We need to be doing this in small community groups where we have people practice and show each other. And I'm a real advocate for creation of peer groups. They can be affinity groups that are organized around whatever people are interested in, whatever they care about. Let's say that you're part of a book club. It could be as simple as that. But then you have somebody in that group who's a facilitator who has the knowledge, and then they catalyze a discussion with people asking each other questions and sharing best practices. But together with that discussion should be praxis, Praxis, do the thing that we talk about. So we heard Mike talk about how we doff. Now let's go do it, and let's do it together, and let's watch each other and provide affirmative feedback. I think that you can talk to a blue in the face, but we don't really change our habits until we start doing the thing that we need to change and do differently.
Thank you, Ludivina, for that question and that comment, and Dr. Bergman for the response. I see here a question in the chat from Mandy. Mandy, would you mind unmuting and sharing your comment with the group?
Sure. I just, she mentioned about the date when we should expect to go back to work and see people in community health. We have a recovery council and we're not at work. We're still working at home. And my question is there an expected date that we would be going back to work? I mean, we don't have one. And so that's my question. I mean, is there kind of an overview of like when we would be going back to work that somebody knows?
So I guess I'm a little puzzled because I would think that y'all are in the category of healthcare, and healthcare is at work, wearing masks.
No, we work at a recovery council. So we're on several different grants, OSAR, T-Tour, RSS, those types of things. So we're not healthcare.
Mm-hmm.
So,
I guess that you're going to, are you being able to effectively do your work through telehealth?
we are doing telehealth. We are doing limited assessments, things like that. But we're not doing them from the office. I mean, that's why I was asking.
Yeah,
I didn't know how other people were doing this.
So that is not a specific category that we addressed in our health transition team document. By the way, people can access that. Are you in San Antonio, Bexar County, Mandy?
No, we're in Taylor County and Abilene.
Okay, so you should though have access to the governor's report, and there are very specific guidelines sector by sector within that, and I would think that your leadership would be able to utilize that and make some inferences about it. But there's a guiding principle, is that people that are able to continue to do their work effectively remotely are encouraged to continue to do it that way.
Okay, thank you.
Thank you for that guidance. Any other questions?
A question that I think you should be asking, if you don't mind my saying so, is if you if you have a coworker, let's just say a coworker that was exposed to COVID-19 or who had it confirmed, when can that person safely come back to work? And that's guidance that changed recently. So first of all, there has been some testing of asymptomatic people going on that could have happened to your coworker if, say, that coworker was exposed to somebody at home who had COVID-19. If you had a positive test and you were asymptomatic, you're supposed to quarantine now for 10 days, and you must not have had any fever of any kind and not be taking Tylenol or Advil or something that would lower your fever for 72 hours. Okay, that's 10 days and 72 hours. If you are a symptomatic person, if you got sick, it's confirmed that you had the virus that causes COVID-19, then you have to have been at home for a minimum of 7 days from the time that you first became symptomatic. That's number one. You have to be getting better. You have to be, improved. And you also have to meet that criterion of 72 hours with no fever and no Tylenol or nothing that would lower your fever. So when the CDC gives that guidance, it's back to work guidelines, and they do it for regular people, they do it for healthcare workers, and they do it based on testing strategies as well as symptoms. And since testing is still so very limited, most people are going to do the clinical symptom strategy for return to work. And if the testing is available, that's where they want you to have 2 negative tests 24 hours apart. But we're not even using that here for healthcare workers because of our limited availability of the test. So I hope that was helpful to you. I'm trying to keep up myself.
Thank you for keeping us up too. Yeah, it has been, that's kind of been the story of the past 90 days is keeping up with new news, new data, new guidelines. So we appreciate your help with that, Dr. Bergman. I want to turn now to the Texas Mood team, which has a few just programmatic announcements before we conclude our session. Mood IT, could you share the screen? And Sedona, when you're ready, take it away.
Thank you, Matthew. So just a few quick announcements as we wrap up this hour. The Texas Mood team is still offering DEA X waiver trainings virtually, and we have our monthly ECHO sessions. Our next ECHO session will be on the 19th. We're also putting together an opioid use disorder treatment boot camp and still continuing to provide assistance with the DEA X waiver process. We are also continuing our subcontracting services, which provide funds for buprenorphine and extended release naltrexone. So our application is still open for that, and we're still processing and executing contracts. Next slide. And this is just our upcoming ECHO schedule. Our next May ECHO is on May 19th, and the topic will be risk reduction. And then schedule after that is here, and we'll send these out as well after the session. Next slide. And these are our upcoming currently scheduled X-Waiver trainings. We are holding a virtual 8-hour full X-Waiver training this Saturday. So you're welcome to register for that. And we are still planning on doing in-person trainings in Tyler, Dallas in June. However, we are able to schedule other virtual sessions as well if you're interested in that. Next slide. Next slide. And lastly, our San Antonio Substance Use Symposium unfortunately had to be postponed this year. However, we do have a date set for next year, and it will be April 30th through May 1st, still at the Henry B. Gonzalez Convention Center. And you can visit our SASIS website for updates regarding that. Thanks.
Thank you, Sedona. And as she mentioned, all of the slides and the session recording will be shared with all of you after this. We have a couple minutes left. And Dr. Bergman, I wonder if we can turn to you now to just some final thoughts from you on what we should take to heart moving forward as we deal with this extraordinary time and also a return to what you described as a new normal.
Yeah, I think we all have to get comfortable with ambiguity ourselves, and we have to help our people that we're counseling, people that we're healing, get comfortable with the ambiguity or learn coping strategies to deal with the ambiguity. Please also understand that as we move forward, we also need to be prepared that there may be indicators that we have to retreat from what we've done. So, here in San Antonio, we've established 4 progress indicators, and those are things that if those are green lights, if this is happening and it's happening well, we can move forward, meaning we can now expand our business from, say, 25%, which is where Abbott wants us to start, and move on to 50% or 75%. And those are, have we had a decline in the number of cases for the last 14 days? San Antonio, that's a no. That's a no. A lot of it's in the jail, but we haven't, strictly speaking, had a 14-day decline in the number of cases. We need to have adequate testing, and here we can only do 1,600 tests a day. By May 11th, I know we'll be where we need to be, which is 3,000 a day, but we're a little early. We need to be able to do contact tracing. So that means somebody's sick, they're confirmed to have COVID. Metro Health needs to be making phone calls to figure out who's been exposed and get all those people tested and or quarantined. And we don't have all of the contact tracers that we need. So by the way, you might want to help recruit contact tracers. They don't have to have special education, but they do need to have a training and supervision. And then the last one is hospital stress. So if those things start to go backwards, if we get warning indicators such as an increase in the percentage of the tests that are positive, we expect the numbers to go up, but we don't want our percent of positive tests to be increasing. If we see a decrease in the doubling time, decrease in the number of days it requires to double the number of cases, or if we see signs of hospital stress, and that means stuff like running out of PPE, those would all be signs that we might have to retreat. So people need to get used to the fact that they're going to have to pay attention and listen to the advisories, and don't be shocked if, 1 week you're told, go out, go do your thing, go back to work, and then 2 weeks later or 3 weeks later, you're told, hey, you have to go back, you have to retreat. So there's a lot of uncertainty, and I would think that for folks that are dealing with addiction and opioid use disorder, that that uncertainty could be very, very destabilizing. So we'll have to come up with positive strategies for helping people cope with changes in the reality and the instability that we have that's around us. And I'll leave you with a final thought. What we said, I like to make reference to my Hurricane Katrina experience, but this was so wise and so helpful. We said to each other every day, we may not be able to control what's happening to us, but we can control how we treat one another. And that's such a simple message. But we do have control over how we're treating each other, and that can be comforting. Even in the middle of a hurricane, that idea can be comforting.
Thank you, Dr. Bergman, and thank you, Dr. Charlton, too, for sharing your expertise today. Thanks to the Texas Mood team, and finally, most importantly, thank you to all of you who have showed up to this session to learn more about how we can improve patient care in this time. Check out the Texas Mood website for more information and future sessions. We hope to see you at one of them, and have a wonderful week. Thank you.
Okay. Thank you.
Thank you. Bye-bye.